Hi everyone. Can you listen? Can you hear me?
Yes,
Hi.
very well.
Yes. Okay. Hi. First of all, I just want to thank you to Keen and the jury, and of course the colleagues at home who voted in our cases, so we can be here today to show you these amazing cases. All of them are different but awesome in their way. So my clinical case is a periapical cyst in the root of the 24. A male patient. Okay. So a 50 years old male patient came to my appointment with acute abscess and pain in the second quadrant. We did an X-ray, as you can see here, and we can see that he has a root, like a broken tooth, in the second quadrant with a big apical radiolucent, and also the dropping posterior tooth, you can see, with no space to do anything in the lower. He also has 2 roots in the lower jaw. And well, first of all, we give him some antibiotics so we can control the infection. And after that, he came again so we can do the treatment plan. Because this image is so big and so close to the maxillary sinus, we perform a 3D exam so we can see how big it is, and also if we have any communication with the maxillary sinus, that is important. You can see here in the 3D images that we don't have any cortical in the vestibular, the bone cortical. And here, this is a video I did from one of the images in the tomography. We can see that we have a small cortical between the cavity of the cyst and the maxillary sinus. So in this exam, we are pretty sure that we don't have a communication. That's good. So we decided to, as our treatment plan, to extract all these tooth in the second quadrant. They were not good, as you can see here. So this is the intraoral pictures. You can see that we have a very red and purulent gum, a lot of plaque, a lot of tartar. We also had the fistula associated with the 24. And well, none of these teeth are good to maintain. So the decision was to remove it. And then that was what we did. So first of all, we started to remove all these tooth in the posterior and do some alveoloplasty in the bone so we can have space for our future treatment. That will be implant, but I will talk about you later. And well, we extract the roots and then we open a flap. When we open the flap, accidentally, I just damage a little bit the capsule. So we have a little bit of the content of the capsule coming out. That's not a problem. Well, we have this big, as you can see, we don't have any cortical in the vestibular bone, as we saw in the 3D exam. And we have a very big loca in here, as you can see. And well, this is a video I did. I don't know if you can see it. Is the enucleation of the cyst. These kind of cysts are quite easy to remove. They have that capsule, so it's easier to remove it all. You have the size comparing with the blade here at your right. And well, because the hole was so big, we regenerate with 1.5 grams of biomaterial, and then we put a membrane on it. After that, we close the flap with the nylon 5 zeros. We try to close everything by first intention. Mostly, like the most important part is, of course, the area near the bone, the regeneration. In the back side, it was not easy to close everything, so that's okay. They are alveolus, so there is no problem. Well, we here you can see in the pictures the difference between the first image we saw in the beginning of a presentation, that we see the dropping tooth and no space for any kind of rehabilitation, the aspect of the gum. And then here in your left side, you have the space that we have now after all the extractions. And we have very good space for posterior rehabilitation of the lower and the upper jaw. So the patient went home with some indications, cold and soft food, ice on the face, the using of the gel and the moisturize, and also he was taking antibiotic, the amoxicillin with clavulanic acid for 8 days, and also painkillers and anti-inflammatories. After 4 days, I saw the patient. It was perfect. He said he doesn't have any pain at all. He stopped the painkillers after 2 days. And the only complaint he had was that he noticed the bruiser in the cheek, but it was not painful, so it was okay. No swallowing. It was perfect. So after 7 days, we removed the sutures. So this is the healing aspect after 7 days. As you can see, it's quite good. We still have a little bit of inflammation. It's normal in the incisions mostly. So that's good. We did a new X-ray. You can check here. We have the space completely filled with the bone. And we are looking to this X-ray, and I don't know if you are thinking about what we are going to do next. So, well, first of all, we are going to remove the lower roots. They are not good. So they are going to go. And also he had a small decay, and we will treat that. And also the oral hygiene appointment, because the hygiene of the patient was not very good, as you can see in the images in the beginning. And after that, and after we wait for the healing, we will do the rehabilitation with implants. The patient doesn't want removable prostheses. He doesn't use it now. And well, that will be the future. And we probably will need to do a sinus lift to have space to put the implants in the posterior maxilla. And well, we send the cyst to analysis. Well, it tells us that is some epithelium in their constitution, and also the inflammatory infiltrate, like a chronic infiltrate. That's normal. It's compatible with our initial diagnosis, like it's a radicular cyst. So that's expectable. And after 3 months, we saw the patient again, and this is the healing. We don't have the scar in the 23, and we have a small scar yet in the reboard, like the area where we extract the tooth. That's normal. We will still have to wait a little bit more for the healing, but it has very good aspect. And we perform a new X-ray. It's everything okay. Here we already removed the roots and did the filling on the 45. And there is something I want to tell you about this patient. He referred to me that he has some sinusitis all of his whole life, and he needed to do the pills for it, and it was quite aggressive in the last years. And after we did this treatment, he said that he stopped with the crisis. He didn't have more need to use the pills, and he breathing better. So regarding, we don't have a real communication between the cyst and the sinus. We know that we have always a communication because every structures in our face are related somehow. So that infection that he had here was kind of responsible to the crisis that he had with the sinusitis. So we will wait a little bit more for the healing, maybe more 5 months. So we have a total of 8 months between the extractions and the bone graft. And we will perform another 3D exam so we can plan the implant surgery. And well, after that, the crown, so we can have function again. Obrigada.
So now it's turn of Anna and Olivia Carquac. So the floor is yours.
Hello.
Anna, please.
I begin that time. Okay, in this time. Thanks, Olivia. Thanks, Maria João, for your clinical case. I saw it was a challenging one because you have a lesion in the maxilla, and you already had to begin to trying to have some solution forward. In the future, the patient want to have teeth, so that is important. It's important for us to do a diagnosis and the surgery, but to perform what we are going to do next. So I only have one consideration. It's because of the lab, the anatomopathologies that you had. You had it in Portuguese, so I'm going to translate it because
I can put it on the screen if you want.
No, that's not necessary. No. It's kind of discussion when we have these lesions and we remove it and we send to an anatomopathology colleague. Probably the diagnosis that they put it on her, I'm not really sure that is the correct one, because we have to know what we are talking about and have some knowledge about histology to make the correct diagnose. The final diagnosis, it will be histopathological and a clinical one. So you had a tooth that has a necrosis, that has an endodontic treatment, not really good one, but it had it. So we have a point of the beginning. We have that teeth, and in the description of the relatory, they say that we have, of course, epithelial features, and infiltrate inflammatory, and some kind of mucus, right?
Yes.
So the final diagnosis, it will be a glandular odontogenic cyst.
Yes.
I really don't agree with that. I really think there is a radicular odontogenic cyst. It's the most common one. It's an inflammatory lesion, because the other one, the one that was in the relatory, is not really common, and normally 50% of the time, 70% of the times it appears on the jaw, not in the maxillar, not even on the right posterior area of the maxilla. By the way, it's quite normal that these radicular odontogenic cysts has a little bit of features that can be confused with mucus. That's why, for me, the final diagnosis that you made of radicular cyst is quite really well done, and we should not consider the other one. And the other one is really, really rare, less than 0.5%. So probably is not that.
Yeah, probably the person who did the analysis is not familiar with the oral cavity.
Of course.
probably. So,
Okay, thank you. Olivier.
Thank you, Maria, for your case. Appreciate the fact. I mean, we have so much diversity in the cases submitted today, so it's very interesting cases. Thank you for your presentation, Maria. Just a question: did you perform any punction of the lesion before entering it?
No, I punched it by accident.
Yes.
So the fluid started to come out, so it was difficult for me to remove the fluid after it. I
Okay.
wanted to do it, but then it just came out,
Okay.
and it was not time to. So
Okay. So there was no pre-surgical punction to see the content of your lesion.
No.
Okay. Okay. I understand that from a periodontal perspective, I mean, point of view, the prognosis of the molar was very poor. What about 2.5? You removed 2.5, right?
Yes. Well, they all have mobility,
Okay.
and due to the position of the tooth, because the patient has no teeth in the lower one, no tooth in the lower one for a lot of years. So we can see that the other ones just started to moving, and
Yeah.
I think that it was not a good idea to maintain that. So because the idea since the beginning is to rehabilitate with implants, because the patient doesn't want removable prostheses. So
Okay.
I think it's a better treatment, because the other one is already with mobility, and we didn't know for sure if we have space because of the dropping, and if the tooth after like the oral hygiene, we can maintain it with like mobility 1. But also we have to do like endo treatment and crown to reduce the size. I don't know if it's a good idea.
I mean, it
I
was
believe
prosthetically,
it was
indicated.
more that kind. If the patient didn't want implants, maybe we try to keep that tooth.
Okay.
To a prosthesis, maybe, but.
Yeah. Second question. I mean, due to the bite collapse, you had this elongation of the molar, especially the molar area. You talk about alveoplasty. I mean, how much bone you removed?
Maybe. Well, I don't know the millimeters, but it was quite a lot, because when I removed the tooth, the septum of the tooth was very long. So when we remove the tooth and the patient bite, we saw like, I don't have a picture, but it was like the bone was dropping too.
Okay.
So the idea was just to nivellate with
the
bone in the 24. It was quite good. I didn't remove as much as maybe it will be needed, because I don't want to lose that bone, like the high important for the implant placement after. Even with the sinus lift that maybe we'll have to do, because we don't have millimeters enough. But I will try to keep as much as possible of the natural bone.
Yeah. Did you perform any ridge preservation in the molar, or no? You just left the alveole, the socket, like
yeah, I put the rest of the bone, like I distribute in the alveoles, and then I put some sponge, like collagen sponge, just to help the healing. But I didn't put bone.
Okay.
Also because I couldn't close in the back area. I didn't close, and I thought maybe it was not needed, because I removed a lot of high, so the size of the alveolum was quite small.
Okay.
Like the inside the bone.
Okay.
Yeah.
And you took a picture, OPG, at 1 week after the procedure. What was Why?
Well, I wanted to took it before the surgery, just to check. But then the patient was kind of tired, and then I thought maybe we could take
After the
after.
surgery, to have a
Yes,
to have a
yes,
kind
after,
of baseline. Okay.
like to compare like
Yeah.
the beginning and after surgery. But because the surgery was quite long and the patient was a little bit tired, and well, all the blood and so on, I thought maybe we could take the X-ray the day we took the sutures.
What will be the next step? Will be the implant placement, correct?
Yes.
When are you planning to do it?
Well, we did the surgery in November, so December, maybe June, July, I will do a new 3D exam. It was 8 months, like between the surgery and the 3D, and maybe I believe it's already good to go. So we will do the 3D and then we will plan it.
And your plan is to place the implant, even if you need sinus lift, we will do it concomitantly at the same time?
It will depend of if we have enough bone in the back. If we have, I mean, if we just missed like 2-3 millimeters, like to have the sinus lift, maybe I believe we can place the implants at the same time with the sinus lift. But if we need more millimeters, it's better to do first the sinus lift and then wait a little bit more and then place the implants.
All right.
But
Can I suggest you something in this case?
Yes.
I mean,
please.
why waiting so long before doing the sinus lift? Because I mean, the treatment will be very, very long, yeah? If you wait now until June to do the assessment and eventually do a sinus lift and wait again like 6 months.
Well, I don't know if we need like if the amount of bone that we have in the posterior area, it's like small, I don't know, like 4 millimeters or 3, I don't know. I'm afraid that we cannot have a good osseointegration.
Oh no, I'm fine with that, no problem. I mean, you don't need to do the implant placement the time you do the sinus lift, but you could do the sinus lift much earlier.
Okay, yeah. Yeah, we can, yeah.
Okay. Thank you, Maria.
Thank you. Thank you.
Okay, thank you.
Olá a todos, o meu nome é Maria João Falcão e sou uma das vencedoras da primeira edição do concurso de casos clínicos organizado pela Casa Comercial Quim. Estou aqui hoje para vos falar da minha experiência em participar neste concurso. Foi o meu primeiro concurso de casos clínicos. Participei com um caso de um quisto radicular associado a uma raiz com um tratamento endodôntico falhado, um quisto de grandes dimensões, que foi necessária a sua enucleação com regeneração para posterior reabilitação com implantes. A minha participação neste concurso foi potenciada pelo colega da Quim que me visita nas clínicas, que me falou dele, e eu pensei, por que não? Uma experiência nova. Fiquei entre os primeiros 5, fiquei no 3º lugar. Tivemos um webinar onde apresentámos os nossos casos clínicos, foi uma experiência muito gira, foi a minha primeira presença num webinar a apresentar um caso clínico meu, e recomendo. Convido-vos a todos a participar nesta próxima edição que há de abrir entretanto, com um dos vossos casos clínicos de cirurgia ou periodontologia, para também vocês poderem ter a hipótese de ser um dos vencedores do próximo concurso. Até lá!